comments here as we begin. I'd like to share with you our work and advances in the diagnosis and treatment of BPDCN, elastic plasmacytoid dendritic cell neoplasm, and hopefully as a reflections and extrapolation to some of the more common myeloid malignancies. As an active clinical trialist here in America, here are my disclosures. We will definitely be talking about off-label, off-protocol, future direction approaches. Elastic plasmacytoid dendritic cell neoplasm. This is a disease with worldwide incidence, really unknown until the last decade, and a fairly aggressive hematologic malignancy, with median overall survival generally less than 2 years in almost all series. This unmet medical need has now had its home in that it has its own classification name that has been crystallized since 2008 WHO classification. BPDCN in the clinic is a very strange and difficult to diagnose disease. Many of you have may seen a case, but it usually is mixed up and confused for leukemia cutis, so AML with skin lesions, CMML with skin lesions, or even cutaneous T-cell lymphoma or other lymphoma presentations. But make no mistake about it, BPDCN is its own entity. It appears to be a hybrid between leukemia and lymphoma, and it has 4 major compartments. Number 1 is the skin. Almost all patients at some point will have cutaneous involvement, not always at presentation. The concept is that the lymph nodes, CNS system, and bone marrow are also involved. So 4 major compartments for diagnosis and follow-up. Number 2 is that the disease, BPDCN, can go anywhere. So unlike some of our AMLs, which usually tend to be bone marrow and blood with rare extramedullary, this is common for that. And that may be because it expresses CD56. And the hallmark of the disease is difficult. The only thing that's 100% of cases is overexpression of the surface marker CD123, IL-3 receptor alpha, and then you usually will have positivity of CD4 and 56. So that initial triad we thought would be enough. So we told people, think 1, 2, 3, 4, 5, 6. I think it's a good start. But now we know we need to differentiate BPDCN from AML leukemia cutis and other entities. And so 3 more markers I would encourage you to add to your panel. TCL1, which you will not see positive in AML, is positive in this disease almost 100% of the time. TCF4, and then CD303. If you have these 5 or 6 markers, you'll have 100% sensitivity and specificity for this rare disease. The molecular mutations are usually centered around the ones you already know from MDS, CMML, and AML, and they are the usual TET2, ASXL1, RAS. One interesting mutation is the ZRSR2 in BPDCN, which is a splicing mutation you may recognize from MDS and CMML. That's common in this disease, and of interest, it's on the X chromosome, as BPDCN is 5-to-1 male predominant. So usually older patients, 70 is the median diagnosis, usually male, 5-to-1, and outcomes are 1.5 to 2 years historically with chemo regimens. The first-in-class agent, which I helped to lead and pioneer, Tagraxofusp, or TAG, by Stemline Menarini, is the first-in-class and only US or EMA, FDA, or EMA-approved agent for all of BPDCN and represents the start of a new era with CD123 targeted therapy. So as we think about BPDCN together, this rare disease is now starting to come to the mainstream of hematology. You will start to see it on board certifications, recertifications in the clinic now that we have the TAG-approved drug. After all, BPDCN is a visual disease, and so for the first time in my life, I have to talk to dermatologists every day. I never thought I would do that as a hematologist, but they have been key colleagues in the diagnosis and management of this awful disease. Seen here are pictures from myself and colleagues all over the world. BPDCN usually presents as maculopapular, purplish, dark red lesions, but they can develop into really, really nasty plaques and large tumor balls if left untreated, and it does underlie how rapid progression this disease is, and so patients are at risk for TLS, tumor lysis syndrome, upon treatment. So as we think about BPDCN, why is it so rare? Well, first of all, in the US, we really do think it's a rare disease, maybe 500 to 1,000 cases a year, but I will say that APL, other diseases, hairy cell leukemia are as rare, and we have nice treatment programs and recognition there. The nomenclature has changed every single time there's a WHO revision, every single time. Here's a chart that shows you that, and they're really different names from each other. Finally, in 2008, this BPDCN finally came as a crystallized name. It hasn't changed since. It used to be under AML, then its own unique myeloid neoplasm, and then kind of amazingly and unexpectedly, it changed categories again in the latest 2022 to dendritic cell and histiocytic neoplasms under the heading of PDC neoplasms to differentiate the mature PDC, which can be more of an entity in CMML or AML, and then of course the BPDCN entity that we'll be talking about here. So that's interesting. The name at least has stayed the same, but categories change. That confuses the diagnosis over time. As I mentioned to you, unfortunately, awful dismal outcomes. Some of the series shown here on the left. Usually a CR rate of 40 to 50%. It's usually like an AML type of a CR rate, blast below 5%, count recovery. It's only about half the patients with usual 7-3 AML or usual CHOP lymphoma or ALL therapies, and then super high death rates. Most patients are older, frail, comorbidities, other malignancies, and then the overall survival, as I mentioned. So really, as I got into this field, when people say urgent unmet medical need, we really had that here. I started to do with our team at MD Anderson a search for targets. There were none. There were no targets for BPDCN. One obvious one that came to our attention was the surface marker CD123 seen in 100% of BPDCN cells. That's the IL-3 receptor alpha, as we mentioned. And one of my colleagues, Dr. Art Frankel, in the 90s and 2000s was working on a molecule that would be able to target that. We also have second generation CD123 agents we'll discuss here, including IMGN632, pivekimab, and then CAR T cells. So let's think about IL-3 receptor alpha CD123. Why is that so important? And it's really the crux of the issue for this talk. That's because CD123 is overexpressed in the majority of leukemia stem cells. So most of our AML patients, I would say 75 to 90% will have CD123. It's the transmembrane alpha chain of the IL-3 receptor. It's expressed at high levels not only on PDCs, plasmacytoid dendritic cells, but also monos, basos, eos. And it is kind of this important factor that you have the binding of IL-3, then you have the heterodimerization with the common beta subunit on this IL-3 receptor, and then this leads to the usual proliferation, cell differentiation, cell signaling for these important white cell subsets. 100% of patients with BPDCN, as I mentioned, but also the vast majority of patients with myelofibrosis, CMML, AML, even lymphoid diseases, Hodgkin's lymphoma, then you'll have hairy cell leukemia, mastocytosis. So quite a wide array will have this CD123 expression, obviously making it an attractive target outside of BPDCN. So in the BPDCN story, now this is about 10 years old. We started to take this Frankel agent, which is in fact the Tagraxofusp, now known as SL401, really one of the great stories in our rare disease kind of category. So this is a truncated diphtheria toxin payload, modified, fused to a human recombinant IL-3, given as an IV drug, 15 minutes with ample pre-medications, usually given as 5 days. And with this agent, with really just one cycle in this pilot study published in Blood 10 years ago, we showed that the vast majority of patients with BPDCN, this is a large study of 11 patients at that time, almost all of them achieved a remission, almost all were CRs, several of which were quite durable. In this pilot study, with accompanying editorial by Fitzgerald from the NIH, heralded the possible start of a new era in this ultra-rare disease. And so with the STEMline team, we took these results with the pilot study and launched the first ever multi-center, multi-cycle prospective phase 1/2 trial, building on the pilot results. And it was a phenomenal experience. Led by our team at MD Anderson, my mentors, Dr. Marina Konopleva, Professor Hagop Katarjian, the chair, we were able to take this drug with the STEMline team to FDA approval. An extremely large trial of patients with this rare disease, including 29 frontline patients. We demonstrated a frontline overall response rate of 90%, 90, with 72% complete remissions, and a respectable 67-68% of the relapse refractory setting. 5 days dosing, the cycles were 21 to 28 days, and this ultimately led to FDA approval December of 2018, marking not only the first FDA approved drug for BPDCN, but also the first and only FDA-approved drug targeting CD123. And as with any new drug, we experienced some things together for the first time. One was the absolute rapid clearance of these extensive skin lesions. We've never seen anything like this before in the clinic. This was one of my patients, 71-year-old woman with extensive disease in all three of the major compartments, skin, lymph node, bone marrow. After just one cycle, she had complete resolution and durability of the resolution of the skin lesions, completely all gone. Sometimes patients will have pruritic lesions or maybe not feeling well to go outside to socialize with these skin lesions, and so the disappearance of them can add to the quality of life of the patient. This older patient, who was a bit frail at presentation, improved her performance status and was able to go to an allogeneic stem cell transplant, another amazing benefit of the Tagraxofusp program. Well, furthermore, into the EMA, the Tagraxofusp agent was put forward, and there the EU did ultimately approve the agent January of 2021 in adults in the frontline setting. They did acknowledge the data set from the previous slide, also correctly noting the capillary leak syndrome, which the FDA also noted. So FDA noticed the capillary leak syndrome as we expected. That's a so-called black box warning. 18 to 20% of patients will get it, usually restricted almost always to the first cycle, but it can be potentially life-threatening. And we did have 1 or 2 deaths early on with this, and then after we modified based on albumin and other parameters, it's a quite manageable and expected side effect and can occur at low grades as well. So in this data set, the EMA also gave the approval in the frontline setting for adults. Interestingly, I forgot to mention, the FDA actually gave broad approval ages 2 and older, so it can be used in the pediatric setting in the United States as well. In terms of safety and tolerability of this new agent, I always try to say new agents bring new toxicities, but with experience, education, mitigation, you can address that. And my great colleague and our friend who just introduced me, Dr. Mansour Al-Fayez, was one of the great collaborators with me over the last 10 years, and he wrote a beautiful paper that everyone should look at, in which this algorithm is well cited in our field. What we realized is we can save lives. We can prevent death by a very easy system, which is shown here. Capillary leak syndrome, the accumulation of life-threatening fluid in the heart and lungs, can be kind of addressed by looking at these. First of all, before giving TAG, you have to know the albumin. There should be a certain parameter, 3.2 or above. During the administration of the TAG on the dosing days, watch the albumin and daily weight daily. If the albumin is too low or the weight is too high, you must hold the drug. You can replace with albumin and Lasix, and then monitor again. You have basically a 10-day window for the 5 doses. If the patient is getting super ill with the capillary leak syndrome, we found that high-dose steroids given rapidly and several doses can literally prevent the patient from death, ICU. If the patient does go to ICU, vasopressors early on are preferred as you're trying to watch for volume with the high-dose steroids. We have many patients who were able to either be salvaged from the ICU or prevented from there, re-challenged with the drug, and did very well, because this is usually a first dose phenomenon and exposure. I do spend a lot of time in the clinic talking to the patient about the capillary leak syndrome, so they're aware, family members, pharmacists, nurses, and we have had really no problems, major problems with this post-approval. And in Europe, I would say my colleagues in Europe do an even better job in terms of education, prevention, monitoring. So I think the center of care, the physician team, pharmacists, nurses, it's fairly well managed in the real world setting. One such example of this capillary leak was a young patient of mine, 30-year-old male, who came to get TAG-based therapy for newly diagnosed BPDCN, and he did experience capillary leak in the first cycle. In his case, it was a bit unique, fairly fit young man, kind of massive fluid gain in the first cycle. We did cardiac imaging, which was really quite a bit of fluid around his heart, consulted cardiology. Interestingly, they did a cardiac MRI, which we have not done previously in our patients, which showed such massive fluid infiltration in this young man that the radiologist called me and said, "Hey, I think this patient has cardiac amyloidosis as a second diagnosis." Well, that's weird. Why would he have that? Diuresed the patient. Within less than the first cycle, we re-imaged and everything was completely gone. It just ended up being a fluid presentation in this young man. He never went to the ICU, steroids, diuresis. He got re-challenged with multiple cycles of TAG, went to an allo transplant. He's alive and well now, 3.5 years after this incident. The suggestion is capillary leak syndrome can happen. There are techniques and tools to reverse it. Patients can be re-challenged and do well later on. So it's part of knowing about this new drug. Well, what about the long-term benefits of Tagraxofusp? I'm really pleased to show you this hot off the presses, our latest paper in JCO. I'm really proud to have collaborated with the Stemline Menarini team to bring this, which is to show not only the 3 stages in the New England Journal paper, but a 4th stage. So a total of 89 patients treated, the majority of which 69 were frontline patients. And you can see some of the data on the slide here. Essentially, out of these frontline, 65 patients received the 12 microgram target dose. And out of those 65 patients, the majority of which, 92%, as you'd expect, had skin involvement. Overall, we found no new safety signals with the 3-year median follow-up and a very respectable CR rate and overall survival. I think also the key with giving the tag agent is people do not lose the hair, very few neutropenic fever admissions, very well-tolerated drug. In the first cycle, you watch for transaminitis, so AST, ALT, and 50% elevation, thrombocytopenia, transient, the capillary leak, as we talked about. Usually the subsequent cycles are extraordinarily well-tolerated. Many patients are able to bridge to transplant despite older age, and then the median overall survival probability at 12 months, very, very nice at 55, and then up to 24 months at 40%. Here's the Kaplan-Meier curve. Again, median follow-up of 3 years, a very nice tail to the curve, and we have many of these patients still active in the clinic in the long-term follow-up setting. And so the summary, I think, for this first part then, for the Tagraxofusp tag SL401, is that in a disease of rarely understood, very dismal outcomes, older patients, you have the first-in-class targeted therapy, CD123, diphtheria toxin-based, super high response rates, particularly in the frontline setting, with the majority being complete remissions, high rate to bridging to transplant, capillary leak syndrome, as we discussed, you must be aware. And then amazingly, this drug is now in trials in combination monotherapy throughout myeloid and lymphoid malignancies, now even including into the ALL space. So beyond the Tagraxofusp agent, I'm happy to tell you that other sponsors are working on the CD123 space, so we have a brand new field. The second generation is known as IMGN632 by the Immunogen company, and this is a novel CD123 targeted platform known as an ADC. In this experience, which I presented publicly at the ASH meeting several years ago, first concentrating on relapsed refractory patients, 29 patients, median age of 72, mostly male, as we would expect from the historical, mostly skin involvement, but they're a heavily pretreated group of patients for this first data set. You can see here primary refractory over half, 2 or more therapies in half, prior intensive chemotherapy in 50%, prior TAG in almost 50%, prior transplant in almost a quarter. The IMGN 632, now known as pivekimab sunirine, is given as an IV Q3 weeks drug, can be given as outpatient starting in the first cycle. Overall, in these first 29 patients, no capillary leak syndrome reported, no drug-related discontinuations, and some rare AEs as shown here, including thrombocytopenia, neutropenia, hyperglycemia, a couple of cases of liver-related AEs. So generally well-tolerated agent, overall response rate. Now this is in relapsed refractory, heavily pretreated. So a respectable 29 to 30% in this setting, including with prior Tagraxofusp treated patients. No major safety signals, as I mentioned. And so this program has now moved into the frontline setting, monotherapy, BPDCN newly diagnosed, and we await those data set. Other forms of targeting CD123 team are through CAR T cells. Obviously, we're very excited in the lymphoid space, CD19 in particular, with multiple approvals. Not quite the excitement yet at BPDCN and AML, but we're trying. So the first CD123s are there. I think the concept here is a good one, that you have a surface marker that's accessible to therapeutic intervention, but there has to be a therapeutic gradient between the normal hematopoietic stem cell and the malignant stem cell. Preclinical studies have been conducted by our colleagues around the world, France, MD Anderson, Dana-Farber, and others. I think the key is that this field is still super early. The Selectus trial that we started, the first patient actually experienced death, and we published that case report as a clinical correlation autopsy to the clinic. It was an older gentleman, 78-year-old man. So we closed that arm, but the AML is doing well and is actively enrolling. The City of Hope product showed 2 patients, I think initially were treated with BPDCN, some early responses, again, in older patients. And so that trial, we await the final results of that. So there are colleagues who are working on CD123 CAR T. Of course, you know about CD123 bispecifics. Let's see if we can apply some of those into the BPDCN field and not just in AML. Moving beyond CD123, we have the BCL2 program. Everyone is very familiar with that from all the other diseases. But did you know that in our BPDCN, it actually expresses super high levels of the BCL2 and appears to actually be dependent on this protein, maybe even more so than AML. In a recent, actually not so recent, 5-6 years ago, paper published by our groups, my group at MD Anderson, Dr. Lane and Dana-Farber group, who showed that BPDCN is even more expressing and dependent on BCL2 than even AML. And in this program, preclinical to clinical studies, we gave venetoclax in preclinical models and then into 2 patients who were multiply relapsed refractory older patients with transient but powerful responses as a monotherapy published in Cancer Discovery, with the suggestion being that venetoclax has activity in BPDCN, but possibly, as we've seen in other programs, in combination may be its best approach. And so building on that, at our MD Anderson Center, we did give the Consortium hyper-CVAD regimen with venetoclax to 3 patients with BPDCN, borrowing from an ALL paradigm. And all 3 patients, including 2 relapsed refractory, had very nice, beautiful CRs. All 3 were able to go to an allo transplant and did very well. And so this combination approach of chemotherapy with ven, which is now becoming popularized throughout the malignancies, is now crystallized in our ongoing MD Anderson-based clinical trial with the comprehensive program of CD123 with TAG, hyper-CVAD, and ven for younger fit patients. Mini CVD ven we'll use in the older unfit patients. In the real world, and particularly across Europe and Asia, many people do not yet have access to the 123 drugs, or some may not qualify for them. So in this real world setting, very important to me, especially if you call me for a referral, we must think about the global incidence of BPDCN. It's everywhere. Ven-HMA combinations, which now have been popularized in AML. We've already been testing in BPDCN for a number of years. We have published data that shows that this program is effective, particularly in the older unfit patients. It can lead to skin resolution and bone marrow reduction of blasts. Every once in a while, we have had patients who can go to stem cell transplant who were unfit, unwell, and then improved the PS. We also combined with the Mayo Clinic in Rochester, Dr. Naseema Gungat, Dr. Teferian team to publish a series of 10 patients between our 2 centers. Again, the whole goal was real-world patients, median age of 70. All of them had comorbidities, some renal dysfunction, concomitant malignancies, and again, either aza-ven or decitabine-ven proved to be some form of an active treatment for these patients who really cannot tolerate chemotherapy or 123 agent. And even 2 of those patients were able to ultimately bridge to allo transplant. And so we've crystallized that approach now in a clinical trial, which is to give it as a triplet. So SL401 tag, aza-ven, we built up from single agent to doublet and now triplet, as I've sort of shown you the data here. This is open in 3 centers in the US, Dana-Farber, MD Anderson, and City of Hope. I really think this is a very nice approach, particularly for the older unfit patient or even the younger patient, to give this triplet in a clinical trial setting. What about chemotherapy? We're trying to think about global burden of BPDCN. So CD123 story is fine. We've talked about that. Venetoclax is fine. Sometimes not everybody has access to these agents. Well, one good part is from the chemotherapy era, when I look back, I found 2 essential components that I think are worth keeping in the modern era for BPDCN. Number 1 is that of CSF burden of this disease. This was a signal that was missed with the excitement of the targeted therapy era. Dr. Consortium and I went back and looked at our series of 100 patients at that time, and to our surprise, we found that 22% of our patients had a CSF positive at some point in their BPDCN course, half of them frontline, so not all at the time of relapse. These patients were usually occult asymptomatic, meaning they were picked up on a routine lumbar puncture. And the CSF positivity cohort appeared to trend with significant p-values for some subsets, more anemic patients, more TET2 mutations, higher rate of bone marrow involvement, obviously maybe shorthand for higher disease burden in general. The action plan from this has been game-changing for our BPDCN field, and all groups around the world have adopted our concept, which is we've started to do IT chemotherapy, lumbar punctures. I do 2 per cycle, alternating IT Ara-C, IT methotrexate, exactly as I do in the Consortium hyper-CVAD ALL paradigm. Usually I try to aim for 8 lumbar punctures, that's right, 2 for the first 4 cycles. With this, we've obviously been able to catch CNS positivity quickly, and we've been able to treat it as well. So I recommend that as a big-time practice-changing maneuver. The second part of the chemotherapy era is out of all the regimens, AML, CHOP, lymphoma, ALL, the intense ALL regimen in the young fit patient and then the older ALL for the older patients appear to be the most active chemo-based regimens for BPDCN, so I think there's still a role for that. There's many reasons for that, and several groups around the world have published on that. And it looks like each component of the ALL regimen has some activity. Steroids, BPDCN is a very steroid-sensitive disease. Vinca alkaloids, obviously CNS penetration of the chemo systemically, the IT chemo. A lot of patients with BPDCN are TDT positive, etc. So it does look to be a scientific rationale for ALL-based therapy in BPDCN. To that end, we looked at our own series of using the hyper-CVAD regimen in BPDCN, realizing that it's somewhat of a difficult regimen in some locales around the world because you do have to monitor for infection, sepsis, transfusions. We did see an 80% response rate, CR rate, for patients getting this regimen, with a median overall survival approximately double the historical, 1 to 1.5 years. Again, I still think the key basically from this is some type of CNS penetration of your approach. So again, what we're doing is regardless of what you're doing, even if I'm doing CD123 monotherapy, I'm recommending lumbar punctures with IT chemo to make sure you're penetrating and crossing into the blood-brain barrier. Allotransplant, of course, as in many of these aggressive myeloid malignancies, remains a curative option. The problem is most of our patients can't go. We all know that. Most of these patients are older, sick, frail. But if you do have the young BPDCN patient, in our series, the ones who went to transplant, the median age is 39, so exactly half the real-world expectation. As you might imagine, at our center, this is 17 patients. Very nice tail to the curve, and I do have some long-time survivors now out of stem cell transplant 5 years and beyond. That's a very satisfying approach. So obviously, let me say out loud that allotransplant in CR1 remains a very curative option. And so as we think about BPDCN in the modern era, we know about chemotherapy, so obviously that's still important. I recommend an ALL-based approach. If you can add in the venetoclax, I think that maximizes your response rates. If you have access to 123 therapy, the TAG agent has proven to have a high response rate. The clinical trial, the IMGN, is available in the US and Europe. Of course, if you have an older, unfit patient, HMA-VEN, as I showed you, all patients, I believe, should now get CNS-directed therapy. And then if you have a fit young patient, add in allotransplant in CR1. I do think that the future, if you'll allow me to say, should be that of combination therapy. As we've seen in AML and multiple myeloma, let's move to frontline combination therapy, because when this disease relapses, the outcomes are extraordinarily poor, highly resistant, difficult disease. So can we do CD123 BCL2 chemo for the young fit patients, CD123 hypomethylator, BCL2 for the older unfit patients, CNS prophylaxis for all, and maybe we can eliminate needing stem cell transplant and relapse. Obviously, for the future, I'd like to see more teams exploring and investigating other ways to target 123, novel combinations, and of course, always want to search for brand new targets out there. With the remaining few seconds, I just wanted to show you a few things we're working on for the future. I'd love any of your collaboration on any of these projects. Number one is that of PCHM, prior concomitant hematologic malignancies. This is extraordinarily common in BPDCN. It's become a huge problem, guys, and so we need to really work on that together. I think the key is that 20 to 30% of our patients will have one of these, usually MDS CMML. Sometimes it's in the background, sometimes it's active, but you can also see multiple myeloma, we've seen TALL, we've seen MPNs. There is some commonality in the mutations. Almost all of my BPDCN patients will have TET2. That's one of the big findings. But we do need to work on this together. And how do we do response rates? you have a patient who gets a remission from the BPDCN, but the PCHM is still there, the platelets are not quite 100. When we look at other aspects of BPDCN, our colleagues from France have really tried to think about the genetic and phenotypic heterogeneity, so trying to identify at the level of the PDC, so single cell sequencing, RNA sequencing, transcriptomics, are there other targets and other markers that we might be able to hit? Are there different types of PDCs involved? I think this is very worthy work and may help us identify new approaches to our rare disease. In terms of genomics, I mentioned to you this ZRSR2. This is work by my colleague, Dr. Lane at Dana-Farber, where we were included as well, which really showed that this splicing mutation, which is on the X chromosome, is aberrant in BPDCN, and that may lead to an impaired PDC program. But the implication is that it's a male predominant disease. This is an X chromosome aberration. Is there a connection there? So I'd like to see more work on the genomics of BPDCN at a worldwide effort. I mentioned to you TET2, our group has interest in that. This is by far the most common mutation or variant in BPDCN. I think that could be a board question at some point. Even in patients with quote unquote skin-only disease, you do the bone marrow, it's negative, but if you send the gene panel, many of these patients will have TET2, possibly representing a chip type of presentation, or maybe it's part of the malignant driving clone. We looked at the TET2 in a little bit more detail. So we took TET2 mutated AML compared to TET2 BPDCN, and we found that the eotaxin and RANTES chemokines are higher in BPDCN, suggesting BPDCN is a more cytokine-rich, sort of a hot disease compared to AML. We then looked at TET2 mutations in more detail in BPDCN and found that certain type matters. Can you believe it? So type of TET2 matters. And in this small paper that we published in Blood Advances, we found worse overall survival in BPDCN in the nonsense frame shift splice site, so the major TET2 mutations. Again, I think it's important that TET2 is coming up a lot. So CHIP, now I'm telling you BPDCN, CNS positive, I showed you that slide, those were TET2. You have some ability of HMAs working in this context, so there is something there that we must explore together. Finally, there is a new entity, overlap entity between BPDCN and AML known as PDC-AML. Yes, that's right, I didn't make that up. All these things sound like I made them up, but it's real. This paper from Ross Levine at Sloan Kettering, right at the beginning of the pandemic, beautiful paper, that showed that maybe 3 to 5% of AMLs fit this category. So they're obviously CD34 positive AML, but they also will have the 123, 456. So kind of a PDC population, maybe 2% or more. But amazingly, not TET2, but they found that the majority of these patients are RUNX1 mutated. In pure BPDCN, we see RUNX1 almost never. I would say less than 1%. But in this entity, it's almost all these patients. And that appears to be because RUNX1 is apparently part of the PDC transcription platform. Interestingly, in this PDC-AML entity, they found more skin lesions, worse overall survival. Preclinical models suggested that the TAG agent works very well in eliminating the PDCs and decreasing leukemic burden in this subset. And as I mentioned to you, we have ongoing trials in the US with the Esylprola and Veneza in both AML and BPDCN, so we'll wait to see those results. And so I was asked to write the editorial for that exact paper, and I basically wrote the question, targeting the PDC, is it easy as CD123? And I think, as you can see here, the answer is not quite yet, but it's definitely the start. And so I think that BPDCN is a very complex, heterogeneous, deadly disease. The Tagraxofusp and CD123 story has opened the door to a brand new era of improved patient outcomes. And I'd like to see us build on that with combination therapy, the elimination of the stem cell transplant, elimination of MRD, and really going for the cure for these patients. To that end, we started the North American BPDCN Consortium. I'm very proud to share this with you, published in Blood a few months ago. And in this, we took colleagues from US, Canada, Mexico, across North America, but really multidisciplinary, pediatrics, dermatology, dermpath, hemopath, transplant, med-onc, and we all had a series of expert level meetings asking and answering the top questions in the BPDCN field, many of which I shared with you here. And I hope that this leads to a new era of rare disease clinical trials, discoveries, and collaborations that can change this field forever. I think as we close here that the importance of talks like this, social media, internet is so important now after 3 years of a global pandemic, more important than ever. I would encourage you to reach out to me on Twitter, #BPDCN, @Dr. Pem. You can follow me, MD Anderson, Dr. Alfayez, many of our colleagues on this call. We can safely and nicely communicate the rare disease findings and cases across the world to better help these patients. And so with that, I'd like to thank all of my colleagues at MD Anderson, particularly Professor Kantarjian, Professor Konopleva, my colleagues around the world, and my grant support agencies. And Dr. Mansour, I'd like to turn the floor back to you. Thank you so much for this amazing opportunity to connect with colleagues from Saudi Arabia.
All right.